This program is brought to you by Emory University.
Good morning, everyone. Thank you for those of you who are able to join us this morning. I know with the snow outside, it's probably a little treacherous getting where you need to go. I hope everyone is safe and warm. This morning, we have Daniel Gold, who comes to us from Michigan. He went to University of Chicago for residency, and now he's one of our clinical track research fellows on his clinical years. And he is going to be talking to us about a unique case of coronary artery stenosis. It's all you,
Thanks,
Daniel.
thanks, Dr. Coley. Um, Nice to see everyone that made it. So I'm going to talk about a unique case of coronary artery stenosis. I have no disclosures. So 56-year-old female, past medical history of hyperlipidemia, hypothyroidism, presented to an urgent care originally for dizziness and blurry vision. She noticed these symptoms when she woke up, and it kind of progressed through the day. The dizziness she described as room spinning around her. Really no known triggering events that she could think of, except she had a common cold about 5 days prior with cough and congestion, but didn't have any fevers. She also had this subacute mid-sternal chest pain and dyspnea with exertion over the past few weeks that she noticed when she was climbing stairs that started to limit her daily activity, and it was slowly coming to her attention. And this chest pain relieved with rest after a few minutes. Medications she takes levothyroxine and atorvastatin. No history of drinking, smoking, or drug use, and I had a father with an MI at 75. On physical exam, her vitals were remarkable for a pretty high blood pressure of 218/99. The rest of her vitals were fairly normal. On physical exam, she was comfortable, she appeared well. Um, Her cardiovascular exam, so heart exam, regular rate rhythm, no murmurs, or abnormal heart sounds, but she did have these bilateral carotid bruits, subclavian, and an absent left radial pulse, um, which was fairly remarkable on her exam. She had otherwise normal physical exam, clear breath sounds bilaterally, and she was ANO times 3, no focal neural deficit. She appeared well, she appeared comfortable, no pitting edema also. Um, Her labs were fairly unremarkable for her chemistry and her CBC. Really nothing stands out. Her troponin was negative. This was at the urgent care. LDL was fairly controlled at 83. She had pre-diabetes. Her inflammatory markers were negative. So in the urgent care, they basically did some imaging to rule out a stroke. They got a CTA head and neck, which showed no acute intracranial process, but it did show these scattered small lymph nodes that were thought to be reactive, um, paraspinal soft in the paraspinal soft tissue. Head and neck, she had diffuse mild to moderate atherosclerotic disease of the aortic arch, brachiocephalic artery, carotid arteries, and the cerebral arteries. The impression was no aneurysm, hemodynamically significant stenosis, AVM, or dissection, and no acute stroke that they could see, but she did have these somewhat abnormal findings. And then her MRI of her brain showed no acute intracranial abnormalities. So basically, this urgent care ruled out a stroke and sent her out on meclizine for dizziness, valsartan, chlorthalidone for the blood pressure. And she followed up outpatient with her PCP, who noticed that she had differing blood pressure reads in both arms and referred her to outpatient vascular surgery for further evaluation. And they got a CTA, chest, abdomen, pelvis, that showed severely calcified and ulcerated plaque disease of the thoracic aorta and proximal great vessels. And then moderate proximal left common carotid and left subclavian stenosis. And she had left vertebral artery occlusion as well at the origin. And this was concerning at this point for some sort of vasculitis that was going on. Um, and she was specifically Takayasu arteritis. And she was referred here to Emory to a few different specialists, but the first one was cardiology to work up her angina and her cardiac symptoms. So she showed up in our cardiology clinic outpatient, and got this EKG in clinic, which is remarkable for in a setting of subacute chest pain, not acute chest pain, but remarkable for some T-wave inversions, um, pretty non-specific, but some ST depressions in the lateral leads and some PVCs as well. Um, and then for more workup for these symptoms, she got an echo. I only have one image because it's fairly normal. Shows mild LVH, normal EF, normal RV. The LVH is non-obstructive and normal heart valves. And then she gets a CCTA for workup of her angina. And I will say one of the reasons she didn't go to cath originally is because she had it was kind of subacute symptoms, and then in a setting of vasculitis, there was a little bit of a question about cathing her. So she got this CCTA in an outpatient setting. I'm going to play it a few times. Play it 3 times so people can look at it and try to figure out what they're looking at. One more time. Um, Good. So these are kind of like the pictures that were fairly remarkable. So here you can see a very stenosis left main at the ostium. On the CCTA, it almost looks like it's not even connecting fully on this image. And then on the right side, you can see the RCA, which also has a very, very stenosed ostium. Hard to see much connection at all from the ostium to the rest of the vessel, but her interpretation was severe, greater than 90% severe osteostenosis of the RCA and the left main coronary arteries. The coronaries beyond the osteostenoses demonstrated no disease, and interestingly, the CAC score was 0. And there was circumferential thickening of the right brachiocephalic and left common carotid arteries that were also seen on the test. And this was consistent with Takayasu arteritis. And this basically confirmed her diagnosis, um, which we'll talk about diagnosing it in a little bit. So this is when we met her. So she was admitted to the inpatient cardiology service for accelerated workup of her coronary artery disease and Takayasu arteritis. She was started on DAPT, and the plan was to get an inpatient angiogram. But because of this unique presentation, unique pulses, we consulted vascular surgery, who said no acute surgical intervention. There was no signs of subclavian steal, which is when there's a subclavian obstruction and you do arm exercise, there's retrograde flow from the vertebral artery causing cardiovascular or cerebrovascular symptoms. And then they recommended access through the femoral artery for the cath rather than the radial artery, due to the severe stenosis in the bilateral brachiocephalic arteries. Then we consulted Room, kind of needed their blessing to cath this patient in the setting of vasculitis. And they said, given the circumferential thickening of the right brachiocephalic and left common carotid arteries, they could not rule out vasculitis based on what they had. Even though the inflammatory markers, if you remember on the labs, were low, basically undetectable. It's an indication of systemic disease, and they couldn't rule out active inflammation at the arteries and the arterial walls. So they wanted an MRA chest, abdomen, pelvis to further assess for active inflammation. And they wanted to hold off of the angiogram until that was done. Sorry, that's one page. So we got the MRA and also got a PET scan because they ended up wanting both. And then we ended up finding the PET scan out in the records at an outpatient hospital. But nevertheless, MRI showed severe calcification and moderate wall thickening of the aorta, severe coronary, visceral, and renal artery disease, no mural enhancement to suggest for active vasculitis. And the FDG PET also showed no active inflammation. So steroids were not indicated at this time in the peri-op setting. So she was okay. We had their blessing to go to left heart cath. Here are the images. Originally, you can already see it's like very calcified aorta. You can tell immediately. But this is the RCA. I'll play it 3 times. And this is the left main. So you can see, just eyeballing it, you can see the pretty severe osteostenoses in both. That left main particularly looks pretty frightening, kind of hanging on by a thread. Um, so the interpretation, 90% osteostenosis with the poststenotic aneurysm extending into the LAD for the left main. And she got drug-eluting stent with 0% residual stenosis. RCA was similar, also with the stent with 0% residual stenosis. Of note, she had no other significant disease, which I think we saw pretty clearly on those films. And patient had resolution of cardiac symptoms, and she was continued on DAPT, antihypertensives, and statins, and discharge. And that's kind of the end of our story with her. Looks like on follow up with rheumatology a few months later, they did end up giving her a 6 to 8 week prednisone 20 course. So Takayasu arteritis. So that was her diagnosis. She has it's a large vessel arteritis. It primarily affects the aorta and its branches. 80 to 90% of cases are women, and the greatest prevalence is in Asia. I may have forgotten to mention that our patient was of Indian descent. Um, on presentation, it starts subacute with constitutional symptoms early and then later develops symptoms of vascular damage, and this can include claudication, cyanosis, lightheadedness, pain, changes in the pulses, bruits, blood pressure discrepancies, hypertension. The mechanism are these cytotoxic lymphocytes that infiltrate the vessel tissue, cause inflammation. They release some sort of protein called a cytolytic protein called perforin, and it leads to narrowing, occlusion, and dilation of the involved portions of the arteries. Some people, I guess, get lucky. 20% have a self-limited course, but the majority have a relapsing remitting course that need long-term immunosuppression. To make the diagnosis, so there's a few things you can do. Acute phase reactants may be elevated, but as we saw in our case, it may not reliably reflect the disease activity since it could just be localized in the vessel walls, not so systemic. That's why we got the MRA. MRA and CTA are both used to evaluate the thickening of the vessel walls and stenoses, and they also can both measure disease activity. PET-CT, a little bit less clear of a rule to measure disease activity, and then cardiac cath, also very useful to look at the arterial lumen, but it's also used to measure the core aortic blood pressure if the four limbs are affected. Histology is rarely needed to diagnose these patients, mainly because it's dangerous to biopsy a large artery. It's usually available after like a surgical revascularization procedure of an aneurysm, and then you can get it, and that can help confirm the diagnosis. And it can also evaluate active inflammation. And what you would see is just a lot of cells, mononuclear cells, macrophages, and the vessel wall media, and then intimal proliferation. This is from the 2022 American College of Rheumatology um, like website. It's kind of their diagnostic criteria that they use. So um, the main thing is you need to have vasculitis evidence on imaging, and you need to have symptoms and an age under 60. So, and then there's this point score that they use. And if you have over 5 points, then that's Takayasu arteritis. And you can see our patient had almost everything here. She had pretty diffuse disease. She had like 13 points. But the main point is you need imaging evidence and you need symptoms as well. Differential diagnosis. It's almost impossible to differentiate it from giant cell arteritis, which is the other big, like large cell vasculitis. Takayasu arteritis is more like a higher ratio of females, usually younger patients, usually Asians, where giant cell arteritis is usually Europeans. Both have granulomatous inflammation. Giant cells more external carotid artery branches. Takayasu is more the aortic and its aorta and its branches. And hypertension is more common in Takayasu, which is consistent with our patient. And it's more chronic. Giant cell arteritis can be self-limited more often, and they both respond really well to steroids. And Takayasu usually needs some sort of surgical intervention. But again, it can be almost impossible to differentiate the two diseases. So this is kind of an overview of treatment for Takayasu arteritis. Basically, if you have active Takayasu arteritis, you do steroids and a non-steroidal agent, usually methotrexate or azathioprine, and then you want to taper the steroids when it's controlled so that you don't have to be on a steroid for too long. But if you have vascular changes, you want to escalate your immunosuppression to calm it down. But when there's signs of ischemia and they're symptomatic from progressive ischemia, that's when it gets a little bit more of a multidisciplinary approach. But progressive ischemia, you should consider surgical intervention or revascularization, like in our patient. So the mainstay of treatment are high-dose steroids. Methotrexate is azathioprine are the most commonly used to supplement with the steroids to allow for lower steroid doses, but there's really no proven agent that has been shown to be superior. And then antiplatelets are used to prevent ischemic events. That doesn't have great data, but it's been shown in retrospective studies. Um, and then the 5-year survival is like 80 to 90%. As far as revascularization, it could be necessary if there's critical ischemia, like in our patient. And large aneurysms are another reason to revascularize. And then PCI versus bypass is kind of the same. It's the way you would think about it in a coronary artery. And it can be in a coronary artery, like in our patient, but PCI is preferable for short lesions, and then bypass graft is preferable when the stenoses are very heavily scarred, very lengthy, or if it's just a difficult PCI, that's less likely to be successful. But it's important to control the inflammation in the treated segment because there's a risk of restenosis if there's active disease and it's not controlled. So you can still intervene on the patient if there's critical ischemia, but you would use high-dose steroids peri-procedurally. So our patient had um, no active disease seen, so the steroids were kind of not used. But if she did have active disease, I would imagine she would probably have still gotten the procedure. She would have just gotten blasted by steroids. But ultimately, it's a multidisciplinary decision on if there should be intervention or raising immunosuppressive therapy. There's not a lot of great data out there on revascularization in patients with Takayasu arteritis and ischemia. The only thing out there to date is this somewhat recently published Jack paper on a big registry out of India. There's no prospective data and there's no randomized data, but there's this big registry, and they used a single center database over 25 years and analyzed almost 1,000 patients, but there were almost 2,500 arterial lesions treated with PCI. But these or balloon angioplasty, but these lesions were not only coronary, there was all vessels. So it's just a big registry at a big hospital. And they defined success. This is the definition of success in the paper, was less than 50% residual stenosis. Early success was post-procedural. Late success was after 3 months, but the median, just there was a wide range because it's a registry. The median was about over 3 years. So that was the median, but anything over 3 months, repeat cath would qualify as determining if there was late success or not. And overall, early success was pretty good, 92%. Late success was almost 85%. And then there were 71 coronary lesions treated, which also had about 92% early success, 72% late success. And the biggest risk factor of restenosis and that late success was persistent disease activity at follow-up. And that was strongly associated with restenosis. So the conclusion is most vascular lesions and Takayasu arteritis can be safely and effectively treated with PCI as long as the disease is controlled, and especially if that disease is controlled after the intervention. Just a brief review of some other arteritis. The large vessel arteritis could include giant cell arteritis, which we talked about, but this commonly has high inflammatory markers of ESR and CRP, commonly in older patients, and have those cranial symptoms, vision loss, symptoms of polymyalgia rheumatica, and aortic aneurysm and dissection is a late complication. Infectious aortitis is the other large vessel. That's usually from staph and salmonella. And there's a higher risk when there's an aneurysm, infection, immunocompromised state already. The medium-sized disease, the two main ones are Kawasaki's disease and polyarteritis nodosa. Kawasaki's onset's usually between 6 months and 6 years. It's common in Asians. Risk of coronary artery aneurysm, CAD-MI. Treat with high-dose aspirin, IVIG. This is the diagnostic criteria box. Kind of a high-yield board thing, but fever for over 5 days plus conjunctival injection, oral mucous membrane changes, peripheral extremity changes, polymorphous rash, and cervical lymphadenopathy. But one interesting thing, there are case reports of this happening in adults. So technically Kawasaki's disease can still be on the differential for coronary artery disease. Then polyarteritis nodosa is another medium-sized disease, vessel disease, and that's systemic necrotizing vessel vasculitis associated with hepatitis B minocycline use. Middle-aged, and the symptoms are livedo reticularis, purpura, lower extremity ulcerations, digital gangrene. But something to note about this is that the microaneurysms are not always seen on CT. Sometimes you need an angiogram to see the microaneurysms. And it can affect the coronary arteries. So important to us still. Treat with high-dose steroids, methotrexate. I think this is my last slide. The small vessel disease. There's the ANCA-associated vasculitis, which is microscopic polyangiitis and granulomatosis with polyangiitis. And these are both necrotizing vasculitis of the respiratory tract and necrotizing glomerulonephritis. So these are driven by ANCA, and ANCA are these anti-neutrophil cytoplasmic antibodies. There's one to myeloperoxidase, and there's one to proteinase 3 specific. I guess proteinase 3. And then the other small vessel disease, eosinophilic granulomatosis with polyangiitis. That's Churg-Strauss. So that's the eosinophilic rich necrotizing vasculitis, and that's common with asthma. And it may be associated with an ANCA, but not always. And then just briefly, other small vessel arteritis are immune complex vasculitis. I'm not going to go into them, but just know they're out there. Antiglomerular basement membrane disease, cryoglobulinemia, and the IgA vasculitis, which is Hanoch-Schölllein purpura, which is like those purpura on the lower extremities. That's pretty self-limited. So that's just a quick review of some other vasculitis. And that's all I have. Thank you.
Thanks, Daniel. Does anyone have any questions or comments? All right, well, since we don't have any other questions or comments, we'll wrap up a little early today. I hope everyone stays safe in the snow and stay warm.
The preceding program is copyrighted by Emory University.